Good afternoon, everybody. We'll just wait a minute or so while our colleagues come in. I'm really impressed by the attendance on the evening of a long weekend. But look, I might get started. Welcome to our Luminary series and the Healthcare Resilience for Frailty session. I'm Patricia Davidson. I have the honour and privilege of being the Vice-Chancellor of the University of Wollongong, and it's a pleasure to welcome each and every one of you to our Luminaries webinar series. This series brings together researchers, industry expert and thought leaders for a 1-hour conversation every fortnight. And we will discover how research and collaboration at the University of Wollongong and our partners locally and internationally is tackling global challenges. But before we begin today, I would like to acknowledge country. On behalf of the university, I wish to acknowledge that country for Aboriginal people is an interconnected set of ancient and sophisticated relationships. The University of Wollongong spreads across many interrelated Aboriginal countries that are bound by this sacred landscape and intimate relationship with that landscape since creation. From Sydney to the Southern Highlands to the South Coast, from freshwater to bitter water to salt, from city to urban to rural. The University of Wollongong acknowledges the custodianship of the Aboriginal peoples of this place and space that has kept alive the relationship between all living things. Our university acknowledges the devastating impact of colonisation on our campus's footprint and commit ourselves to truth-telling, healing and education. So let's start our conversation. This conversation is both critical and timely. With an ageing population, our healthcare system is under immense pressure of meeting the needs of a larger number of older people, which in essence is a celebration of how well healthcare has advanced. Do you know that every child born, 1 in 3 children born today will live to be 100? That's pretty phenomenal. So it really calls on us to reframe and refocus our healthcare system. And increasingly, because of the increasing number of older individuals, both in our hospitals and communities, there is an increased emphasis on frailty, which is a clinical syndrome most commonly associated with aging, but not always, but leads to loss of independence. And current research and our practice, and many of you here on the call today, will recognise that often our healthcare system does not meet the needs of individuals and their families. So today we're going to have a great conversation because it emphasises the importance of multidisciplinary care and coordinated approach to address frailty, improve quality of life of patients and reduce the burden on our healthcare system. And importantly, today we'll hear from experts in the field that are going to lead us on some data-driven approaches. I'm delighted to welcome our panellists. And firstly, Associate Professor Caleb Ferguson is a Principal Research Fellow and Associate Head of School at the University of Wollongong. Caleb is an NHMRC Emerging Leadership Fellow and has a strong program of research for stroke prevention, cardiovascular disease, frailty, and digital health. He is also has an appointment with the Western Sydney Local Health District and holds adjunct appointments at Western Sydney University, UTS and QUT. We're also very fortunate today to have Professor Richard Lindley with us. Richard is a world-renowned gerontologist and stroke physician, and he leads a portfolio of international clinical trials and projects that assess new treatments, particularly for those with stroke. As a consequence, he has a very keen interest in frailty. And Professor Lindsay's work that you'll hear about today covers a range of geriatric medicine, frailty and stroke. Dr. Julie McDonough is a registered nurse and senior research fellow focusing on frailty at the University of Wollongong, conjointly with Western Sydney Local Health District. And we are very fortunate today that we recognise Julie as a First Nations woman, and she's from the Cabral clan of the Darug First Nations people. Julie has over a decade of clinical research experience and a specialisation in frailty. And last but not least, we have Professor Stephen Frost, who is a professorial fellow in the School of Nursing, Faculty of Science, Medicine and Health at University of Wollongong. Steve undertook his doctoral studies at the Garvan Institute of Medical Research, and he was recently recognised as one of the top 2% of nursing scientists worldwide. And his current research projects focus on delirium prevention and prevention, frailty, and the risk of adverse events during a hospital stay. So I encourage all of the members of the audience to put their questions into the Q&A function, and we'll try and get through as many of these as possible. So can I start off asking Caleb and Richard, you know, you're both leading the Western Sydney Clinical Frailty Registry at Blacktown and Mount Druitt hospitals. Can you tell us a little bit more about this registry and how you see it improving health outcomes? And maybe I'll start with you, Richard, and then go to Caleb.
Thanks. And again, I'd like to offer my welcome to everyone at this time of the Easter break to join and show interest in frailty. Well, the Frailty Register was really precipitated by a bequest, which is good because it shows that the community are interested in dementia and frailty. And by using this bequest with also funding and support from our institutes, our universities, we've been able to set up this Frailty Register, which is really quite a unique register because we're focusing on people, older people who come to the hospital, and we're just seeing how frail they are and what's their outcome in the next 3, 6, and 12 months. We've been able to answer some questions very quickly with this register. First of all, people are very happy to join such an observational study. And we've got about 600 people, I think, involved now, which is fantastic. Some very early information from this study is that if you're frail, if you're very frail and you end up sick and you're in hospital, you know, you are towards the end of your life. And I think my colleagues at the hospital have been surprised at the death rates of people in such a situation. Now, it's a bit gloomy to talk about that later in the afternoon, but it raises a huge number of research questions and clinical questions. If people are towards the end of their life with a limited time, why are we doing a lot of things that we're doing, such as, you know, an average of 12 medications, invasive investigations? I think we really do need to sit back and think, you know, what is the best way to manage? And the other observation is that the hospital system that's designed on historical disciplines is really not fit for purpose for people who are old and frail. But, you know, it's fantastic working in a multidisciplinary team. And I'd like to hand over to Caleb, who can add some further observations from what we've been doing.
Thanks so much, Richard. I think really just to add to that, I think this has been a really fabulous opportunity to drive a really collaborative effort. You know, multiple institutions involved in this research, supported, as Richard said, through philanthropy, but also through our health district partners as well. And it's also been a fantastic opportunity to undertake capacity building with clinicians, multidisciplinary clinicians, and early career researchers as well in this area, and really to drive research activity in frail older adults, and really with a view to improve the care that we provide to these patients in Western Sydney as well. As Richard said, we've managed to now enrol over 650 patients now into the registry across two quite unique hospital sites. So really, we enroll patients from a number of the wards in the rehab and aged care department as well, and follow them up over time. The average age of patients in this register as well is 81. So these are often people that are often quite excluded from clinical research as well. And I think this also provides us with quite a nice platform to now look at how we do intervention studies in this population, and also provides us with a platform to really do some implementation work to feed back and use these data to drive clinical improvement. So I guess one of the key criticisms of these types of registries is, do we just collect data for the sake of collecting data, and very expensive sometimes to set up and to operate as well. But we're in a unique position that we're located closely to the department, and we can provide quite timely data back to the department around standards of care and data that's really relevant to them. And so we're really interested in future studies as well that really use and apply these data to improve outcomes as well.
So thanks so much, Caleb and Richard. You're collecting real world data in real time that is going to hopefully lead to interventions to improve patient outcomes. How are you finding that this registry is contributing to training of health professionals clinically, but also a next generation of researchers that are going to focus on frailty?
Well, if I kick off with that answer, it's been fantastically useful. Part of the training for geriatricians includes a research project. And, we've been able to use our data to help guide our trainees in getting a really good understanding of frailty, how to interpret data, and to put together a high quality project. I do worry sometimes that some of these mandated projects can be a bit wasteful, but I think by utilizing a resource like this, that it's really got added value. We've get important information. They contribute to recruitment while they're with us. They learn about frailty. They learn about the research methodology, the importance of appropriate consent, data integrity, data privacy. There's so much to learn, and our local health district has been supporting the register because they recognize that this is a really amazing research and clinical capacity building vehicle. So we just got win-win by doing this collaboratively with our clinical colleagues and research colleagues.
Thanks, Richard. It was just a question that's come from one of our colleagues, and I think Ping Yu, who is a health informatics specialist, and she's asked, is there any interactivity in terms of feedback to patients and families from the registry, or is it at the moment, is there any interactive function?
So at the moment, we provide patients with phone calls at 3, 6, and 12 months after their initial hospitalization. So we're not actually intervening in this study. It's just purely observational, but it's the definite want to do some intervention studies. And I think nurse coordinated or multidisciplinary interventions in frailty is definitely on the horizon as well. Also, to add to Richard's point around capacity building as well, I think as we mentioned maybe earlier around our engagement with consumers just only a couple of weeks ago, providing this opportunity for multiple PhD students and early career researchers and clinicians to be engaged in consumer engagement around research and research design and how we can improve the research methods as well, has been really a fantastic initiative. But I guess also reflecting now that we've been running the registry for the last 3 years, we've had 3 clinical nurse specialists now work with us full time across those years. And so I do notice that we've had Katie Clancy's joined us online today as well, who was our first frailty research nurse, and we're also fortunate to have had Caitlin and now Reid Jamal as well, and work as part of the team and really develop their skills in research, including data collection, but also data entry and a lot of other sort of really important research skills.
Right. Thanks so much, Caleb. Steve, can I move over to you? So we're going from Western Sydney to Southwestern Sydney. And Steve, you've been doing a lot of work at looking at some routinely collected clinical data to get a picture of frailty. Can you tell us a little bit about that?
Yeah, thanks very much, Trish. I mean, this work was really driven by some of our senior nursing clinicians in the Southwest. And in particular, it was some senior clinical nurse consultants in orthopedics and neurosurgery that actually instigated this work, because clinically they could see increasing rates of frailty amongst the patients in their specialties. So some of our initial work was looking at older patients admitted under surgical services and looking at who was frail and looking at hospital adverse events. And it was no surprise to the clinicians that we found a strong relationship between frailty and adverse events in the hospital setting. And I think this probably just confirmed what people felt across the hospital. And a lot of clinicians have made comments. And I think Richard, raised a very good point around, is our current healthcare system and the way that we do work in the hospital, sensitive to this vulnerable group across our settings, whether it's in a surgical setting or whether it's in a general medicine setting or critical care setting. So this work has really, highlighted, I think, and given us some idea of the burden of frailty in the acute setting and kind of had us thinking about what we can do about it.
Right. And Steve, you were at the forefront of, I think, one of the transformational changes in rapid response systems, and really on the ground when the MET system was introduced at Liverpool, and that system really challenged traditional communication between health professionals, challenged traditional care boundaries. Learning from the information you've obtained and the insights of the nurses who brought this to your attention, what do you think would be an optimal model of care for frail older adults, particularly in the acute care setting?
Yeah, thanks, Tricia. I mean, I think it does remind me a lot about MET and the rapid response system, because I was fortunate enough to be around when we transitioned from cardiac arrest teams to rapid response teams and seeing the difference that it made. But once again, I think it's very similar in terms of frailty. It's something that clinicians have seen that's changed, and that we can see that it's a local problem and we need to have solutions like within the clinical setting. And one of the advantages, I think, of the original MET system was trying to break down those silos, that nursing staff could call people with specialist skills to come and see patients that they were worried about. And I think in terms of frailty, it's something similar, that we can break down those silos, that we can make sure that patients receive the appropriate assessment and planning of care from a multidisciplinary team that can come into any specialty and facilitate that model of care. So there seems to be a lot of similarities, and even the trajectory from something that the clinicians have noticed has changed, and then looking at how we can respond to that anywhere in the hospital. That the traditional specialties don't become walls to the quality and the safety of care that you receive.
So Steve, looking back, and I'm sure after this webinar and the great research is happening, intervention studies will move forward. Looking back on those times and the great work of Ken Hillman and colleagues, what do you think were the ingredients for making that model of care successful?
I guess a lot of it is that idea that there were local problems and local solutions. So people took ownership of the MET and they felt that they were making a significant change with a model of care that was responding to something they could see in the clinical setting. So I think part of it is around that idea of ownership, that people feel as though they own the approaches that they can take, and that they can make those approaches fit for purpose and feasible and sustainable in their own settings. But I do think there's also a lot of politics sometimes related to it, and I guess that's why we did do the work in terms of hospital adverse events. That if we can describe a burden, then we do have evidence that we need to act. But I think, you know, from the clinicians that I talk with, you know, every day, frailty at the moment is the hot topic.
Great. Thank you. So Julie, can I move to you? And I know, you know, you've done some amazing work in frailty, and in particularly in the context of cardiovascular disease, but it also in younger people in the heart transplant population. So, you know, frailty is most common in the elderly, but we see it in many illnesses where, you know, there's catabolic processes and activation of inflammatory markers and other things. So Julie, can you tell me a little bit about the work you've done, and particularly on how we measure and assess frailty?
Yeah, sure. Thanks so much, Trish. So my work really, as you said, has been in cardiovascular disease, but more specifically in heart failure. So I used to work at St Vincent's Hospital in Sydney for almost 10 years. So I initially started working as a clinical trials coordinator, which kind of started my interest in research. And that was working on a large national heart failure trial. And I was, at the time, I'd worked in the coronary care unit looking after the pre-transplant and post-transplant population and really advanced heart failure patients. So I became really interested in that heart failure research. But as part of the clinical trials job that I was doing, I was assessing frailty in all those patients that we were recruiting. And I became very interested in frailty, particularly in people with heart failure. And as you said, frailty is more commonly associated with aging, or most commonly associated with aging, but actually people with chronic disease like heart failure, frailty can come on a lot earlier. So there's research to show that, you know, it may be something sort of not related to aging processes, but related to chronic disease processes. So essentially someone might have frailty that's related to because of how chronically unwell they are with their heart failure. And in my PhD research, we had a mean age of people that were only 53, but depending on what instrument for frailty we used, frailty was up to 80% in some of the instruments, or, you know, 50% on another instrument, which is a different conversation, which I'll get to. But it found that the rates of frailty were actually very high. Like, we had some people that, you know, might only be in their 20s, but they're waiting for a heart transplant, but they're very frail and very underweight and very unwell. So it was very interesting. And with people with heart failure, I mentioned there about the different instruments. An assessment of frailty is recommended for people with heart failure by multiple societies. So the Cardiac Society of Australia and New Zealand recommends we should be assessing frailty. The European Society of Cardiology also recommends we should be assessing frailty. But there's no consensus about what's the best instrument. And so far research has focused about the impact of frailty in people with heart failure. And we know that it can predict rehospitalization and mortality. But the information about the actual assessment instruments that were being used in heart failure was lacking. So as part of my PhD project, the first study that I undertook with it was a systematic review. And the results of this systematic review revealed that the most common way that people were assessing frailty in heart failure was using the frailty phenotype, which is probably the most commonly used instrument, but it does focus on 5 physical domains of frailty. So weight loss, exhaustion, slow walking speed, low physical activity. So these sort of things which commonly occur in heart failure. And, you know, are they really the most appropriate questions we should be asking someone with heart failure? So people with heart failure can have really commonly and fluctuations in weight. So asking them about their weight loss, is this really going to be a true reflection of their frailty or more their heart failure? So that was really the first part. And the other part I wanted to talk about of my PhD study, we had a look at how good are clinicians at estimating if people are frail or not. So in cardiology and other disciplines, there can be what we've sort of termed the end of the bed or an eyeball frailty test. And this is really where a clinician might stand at the end of the bed. And I'm sure those of you that are clinicians have witnessed this. They might stand at the end of the bed and they go, oh, well, they look pretty frail. So we might not go down this pathway for surgery, or we might not give them this treatment, or we might, it'll dictate their clinical treatments. But really, in this study that we did, we compared a formal assessment of a frailty and a clinician's estimation of if someone was frail, not frail, or pre-frail. And it really was, we looked at correlation and agreement, and it was actually showed that there was poor correlation and agreement between the two. And we concluded that it's not appropriate to be doing an end of the bed frailty assessment. We really should be measuring frailty using a formal instrument. Oh, you're just on mute.
Thanks, Julie. Someone had to do it. So, we think as nurses, we're admitting a patient, and you have, you've got to do a falls assessment and, mini mental and alcohol screening. From your work in instruments and, and in also, some of the specificity you can achieve with assessing muscle strength, what are some of the things that you think we can do at the bedside, particularly for nurses who will be predominantly the people, in acute care? If we know in routine clinics, allied health professionals often assess for frailty. But, someone's admitted at 10 o'clock on Saturday night. What do you think as nurses we should be doing to assess those patients for frailty?
Yeah, it's a good question. And I think you raised a good point about the multiple assessments that us as nurses and other health professionals are undertaking. And there's probably quite a lot of overlap between them. So I do think that as assessing someone who's as frail, potentially we're going to be able to get information about from that, what is their falls risk? Are they at risk of pressure injury because they're not as mobile? So I do think that frailty potentially could be assessed and maybe even replace some of those measures that we are doing and give us more a holistic picture. So I mentioned that there is a lot of different frailty instruments. So in the clinical setting, there could be an index that's created automatically for patients. However, I think that's great, but I do think that that's potentially more of something that could be a screening or a risk score. I do think it's important that as nurses or allied health professionals that are undertaking frailty assessments, that we do an assessment that's a little bit more comprehensive. So doing a hand grip strength, maybe a 5-meter walk speed test, not just something that we can routinely get, because then I feel like it's potentially at risk of just being a measure that's collected and we don't do anything about it. So I think, having a look how people, what is their mobility like, asking them before they came into hospital, what their function was like. And with a little bit more training, I think that nurses are very appropriately skilled to undertake frailty assessments. Sometimes they might take 5-10 minutes, but I think with training that nurses really can be the ones that could be spearheading the assessment of frailty in the clinical setting. We make up the majority of the healthcare workforce, and certainly have the skills to be able to undertake frailty as that sort of risk assessment. But more than that, I think it really can guide their clinical management. And I think we've talked a little bit about multidisciplinary team approach. And this really is the gold standard approach, for many different conditions, frailty included. But I do think in the clinical setting that there's a lot of room for improvement about how that really works and how we can work together better to improve patient outcomes.
Great. Julie, there's a question from Alison Moore. In your work, and particularly in the context of the eyeball test, do you see there's any sort of gender-based differences or biases in frailty assessments?
Yeah, that's a good question. Not necessarily. It was quite interesting. So just off the top of my head, we had a look about people that you might be familiar with the New York Heart Association class, which is a way of measuring symptoms, severity, and heart failure. And we just assumed that people that might be in the higher level of that scale, sort of, the level 3 or 4, which is quite severe disease, potentially would be more easily identifiable as frail, but they actually weren't. So there wasn't really any sort of direct links about, people having how well they were able to estimate the frailty depending on those traits. And it was interesting. Even people can be obese and they can be frail. So, having a look about just their weight might not necessarily be the best way to have a look about to decide if someone's frail, because someone can be obese, but they can be malnourished. So it's quite interesting. When we did have a look, there wasn't really any, things that we assumed would make it easier for someone to be identified as frail. In our work anyway, we didn't really find any particular, ideal person that would be, assessed as frail. It was very interesting. There wasn't really any clear people that were more easily identified as frail.
Right. Well, thanks so much to everyone for sort of setting the scene. I think we've identified, that frailty is common, it's complex, it's burdensome, and certainly has adverse health outcomes. And we know that acute care hospitals are not necessarily always configured to meet the needs of people with frailty, and in particular, older adults. So Steve, I know you've been doing a lot of thinking about this, and I think informed by a lot of your work that has a very system-driven focus. Someone's identified as frail, as Julie's talked about. The nurse does the assessment, and then what are we going to do about it? What do you think is some of the models of care considerations we should have?
Oh, thanks, Trish. Yeah, I think we definitely need a response in the acute care setting to frailty that's hospital-wide. It doesn't need to be as immediate as a rapid response. But I think, within the first, 24 to 48 hours of someone coming into hospital that we identify as frail, but it will have to be a multidisciplinary team. And I think just in terms of just addressing the needs, an individual person's needs within that hospital stay. But I think the actual model will also consider post-hospital transition and ultimately think about even pre-hospital, whether hospital is the right place for someone to come back next time, and looking at someone's, wishes in terms of if they do have another acute episode. So I think the model does have, a need for an acute response, but I think it will have a pre-hospital and a post-hospital response. And we, Caleb and Julie, we've had a lot of this discussion around navigator models that have been used for some chronic diseases. But I think just helping these vulnerable group of people, to be supported, I think in a healthcare system that can be difficult to manage, I think is really the ultimate, I guess, of overall aim of a model of care.
Right. And thanks so much, Steve. What are some of the interventions that we know work in frailty? Would anyone like to comment before we start to move?
Sure thing, Trish. I think core components around diet and exercise, and movement and engagement are really core components of these often complex interventions are bundled together, so it's often quite difficult to ascertain what's the piece in the jigsaw that actually works. And I think, to build on Steve's comment earlier, I think as well we have models of care for frail older adults implemented in our health system, but I think in the inpatient setting and community setting as well, that transition period is often the bit where there's the most vulnerability, and I think where there could be the biggest improvement as well. And the issue around sort of the models that we currently have, I would go as far to say that they really fail a lot of the time to meet these complex care needs of these older adults. And I think one thing that's really important in terms of the introduction of new models as well is that ability to offer local adaptation as well. We've seen things like My Aged Care roll out, and yes, these types of initiatives are really fabulous, but how do they interact in terms of when they're implemented with other existing systems, and how can they be locally adapted as well to meet the needs? I think that the care navigator issue comes up a lot, and there's so many services available. And just speaking with our consumers last week, this was something that they talked about as well, around there's so many different services available. Really knowing what is available is a key challenge, and what they can access and how they go about that as well. And that seems like a no-brainer But the healthcare system is really, really complex, and the social care system. So there's a lot of things that we need to do to improve how people navigate through that system as well, and find out about things that they are eligible for or can tap into as well.
Great. Thanks, Caleb. So Kelly Lambert's asked, the Fit for Frailty program at ISLD has sort of, I guess, some key markers. One of those is shortness of breath, assistance with meals and mobilisation. What do people feel about this as being sort of triggers for identifying people with frailty as compared with a reliable and valid frailty assessment?
Well, maybe I can kick off with this one. It's interesting. Some 10, 15 years ago at Westmead, we thought we would look at what were the syndromes people were coming into hospital under geriatric medicine. Bernard Isaacs had described the old giants of geriatric medicine, which was sort of immobility, instability, incontinence, and delirium, stroke, iatrogenesis. But we actually found there were some very common new syndromes, and they were breathlessness, which just been mentioned, sepsis, and pain. And you know what I think society has forgotten about is that we've had a huge success with population aging, but about 10% of our life is with some degree of disability, and that for many people is pushed to the end of life. And we've got these very large numbers of people who now successfully aging, but becoming very frail. And our systems and hospitals are simply haven't caught up to speed with this huge change in requirement and demand, in need. So, you know, I agree with Caleb and Steve. We've got to do an awful lot more of redesign. For example, in the emergency department, maybe we need to identify who are frail very quickly and think of the alternative tracks. We have got hospital in the home, which has been beautifully developed through the pandemic in Western Sydney and is now a fantastic resource supported by community geriatricians for our patients. You know, we need to think of alternative models, because the emergency department is really good at saving your life when you've had a car crash or a cardiac arrest, but it's really bad at looking after you if you're old and frail and need pressure area care. You know, we've just got historical systems that are now not fit for purpose. And I think, you know, measuring frailty is the start. You know, the frail have been excluded from many randomized controlled trials. So we need to start measuring frailty for our new trials. But we also need to think about new trials that are just focused on people who are frail. You know, what is the best model of care? And that's health services research. And so, you know, if anyone wants a career, this is where to go, because this is a big ticket item. It's hugely expensive for the state government, for hospitals. And I think we could have some substantial savings by disinvesting in what's wasteful and reinvesting in what could be better care for older, frailer people.
Thanks so much, Richard. There's a question from Glenn Paul that sort of asks about the role of primary care in identifying frailty, and maybe even more useful, you know, the pre-frail status. Would anyone like to comment on the state of the science of frailty assessment in primary care?
Well, can I say that we're working with some other groups on trying to get this automated? You know, as Julie mentioned, we're collecting a lot of data. And if we could just pick out the bits that contribute to a frailty score, we might be able to have a pre-label of everyone who's in an electronic medical record system, be it, you know, medical director from primary care, or be in a hospital Cerner electronic medical record. So maybe we can, you know, like we know how old people are, maybe we will just automatically know how frail people are if we join up all our systems.
Yeah.
So, you know, this is a work in progress, and I think will come to fruition in the next few years.
Yeah, I think you're right, Richard. And there's some data coming out that has used AI in electronic health records. But there's also been, you know, a suggestion in the chat, which I'll get the panelists to take on notice, that it might be good to have a community-based registry for frailty as well. So I think you can all put that on your work plan. So the other point that I really wanted to sort of tease out, and Richard, you've commented on allocation of treatment, treatment choices, potentially futility. I've just completed a study with a colleague, Lindsay de Groot, which has seen, which is not surprising, a high correlation with unmet needs for palliative care and frailty. How do we address rational decision-making in people of advanced age in a cure-driven hospital setting? So Richard, I might start with you and then pass to my colleagues. And particularly Steve, you might reflect on how MET has evolved to that issue. Richard?
An observation that I have is that if we follow guidelines to the letter for some particular problems, that if you put it all together for an individual patient, you probably kill them with, you know, massive polypharmacy. And our specialties have been designed really for addressing that one problem, but our patients are coming in with half a dozen problems. So, you know, maybe artificial intelligence is going to help us work out, you know, whether some things are going to work or not. Now, we've done some very interesting work retrospectively, putting in a frailty score in people who've been in previous trials. And we've looked at a few interventions, and what we found is very interesting. Some interventions are increasingly harmful with increasing frailty, and others are just as good, if not better. So you can't predict necessarily which way the treatment direction is going to go, but we really need more of that sort of data. I think one of the things we're getting better at in the hospital system is advanced care planning. And, you know, we're increasingly better at filling out these forms and having the conversation. And, you know, I was in the emergency department today where we checked, and someone had beautifully done an advanced care plan, which we reaffirmed was still, you know, appropriate for someone who was pretty frail. So I think, you know, extreme frailty is a pre-terminal condition. And we do need to have that lens of, you know, we're passing a watershed perhaps when we cross some degrees of frailty, where our treatment decisions must change from, you know, extension of life to comfort, or, you know, appropriateness of medication. And just simple things like if in a nursing home, every resident's on 12 different medications, the opportunity cost for the nurses in dispensing those medications, when nurses might be far better off talking to people, checking the infection control, checking, you know, skin integrity and comfort. So this is what I think I mentioned before about, let's challenge some dogma. Let's disinvest in some of the things that we've been doing routinely because we've always done them. They may be a complete waste of time, and perhaps reinvest our time and resources in a different direction. Now that's going to need an academic push from us on the panel and colleagues who are, you know, joining us on this webinar. But that's our challenge.
Yeah. Well, in the Q&A, we have some comments from some of, again, our information technology experts, Kin Win and Ping Yu, who seem to be very excited about collaborating. So that might be good to really reach out to them to see how we can automate the calculation of the frailty index, etc. But Steve, I just also wanted to sort of pass to you a little bit, because I know the Met system has thought about this of, you know, often once we do get policies and procedures and people do call clinical deterioration, can you talk a little bit about how end-of-life decision-making can be incorporated within a system that is often focused on clinical deterioration?
Oh, thanks, Tricia. Yeah, I mean, it's in the Met data itself that it's not uncommon for a hospital to describe that a third of Met calls result in a limitation of treatment, and that in terms of someone having a clinical deterioration, it's where there's then a decision made about the treatment goals after that, you know, and talking about, you know, what is the wishes of the patients themselves. So Met has recognised that, you know, that many of these Met calls did result in a decision to be made that there would be no further Met calls, or there may be some change in the criteria for Met calls, and that the goals weren't necessarily, you know, transferred to intensive care and critical care. They were more about someone's wishes to be comfortable and making plans about, you know, that are acceptable and to families and patients. So that has come from Met. I guess the challenge often is the timing of when people make those decisions, and I think that's some of Ken Hillman's work, where exploring that. Is it the emergency department, but maybe people are too acutely unwell in the emergency department, and it's something that maybe in the community and primary healthcare setting, you know, after someone's left hospital and had some time to think about what they would like to happen in the future, maybe a little bit more appropriate than when they're acutely ill and you know, distressing for families and patients themselves. So that timing of making those decisions too is important, and I think it may be an out of hospital situation.
Yeah, I think thanks so much, Steve. You know, we've spoken about frailty and different ways of assessing frailty, but I think to date a lot of our conversation has focused on physical frailty. But we know that cognitive dysfunction is part of this syndrome. Would any of the panelists like to comment on, firstly, assessing cognitive capability as part of a comprehensive frailty assessment, but also then how that influences the management of frailty?
I think if I can answer something, Trish, yeah, I do think that's really important, and it's part of my work, which, as I said earlier, was focused in heart failure. There's actually been research that's shown that we're able to better identify frailty if we include cognitive and mood domains in an assessment. So rather than just focusing on physical, so really taking a multidimensional or multi-domain view. And at St Vincent's Hospital, they would be assessing cognitive impairment using a MOCA, or a Montreal Cognitive Assessment. That assessment does take quite a little bit of time, and it can be a little bit burdensome for patients, but it's quite effective. And then using a measure for depression as well, like a depression and medical illness questionnaire. So I think it's very important not to just focus on the physical measures, particularly when we're talking about in the acute care setting. If people are coming in when they're unwell, just focusing on physical, it might not really give a clear picture about what their frailty is, because they are unwell at that time. So when someone else mentioned before about the primary healthcare setting, yeah, I do think that that's a good place to measure frailty when someone isn't sick at the time, to get a true picture of what their frailty actually is. I also think, though, talking about a multidisciplinary team, that in the acute care setting, and this is me coming from my cardiology background, if we identify someone that's frail with a quicker sort of assessment tool, I think there's really scope to then be referring, if patients are of a certain age, particularly, to be then referring them to the geriatric team for a comprehensive geriatric assessment, which has all the cognitive and other measures in there, which Richard would be able to talk more about. But I think that's really potentially a way forward, that more integration between the teams, the medical teams, to then have to be referred to geriatric teams, which are really then the specialists in how we're going to be able to treat frailty.
Thanks, Julie. So we've talked about the registry. We started off our conversation on the registry, and we also identified that we need to have innovative models of care, and what we're doing now is not sufficient or effective. So Caleb, I'd be really curious to hear your thoughts about, how you think data feedback from the registry could help facilitate and enable a learning health system model.
Thanks, Trish. I guess to my earlier point around collecting data for the sake of collecting data, I guess there's this notion of the learning health system model that is getting quite a bit more traction, and people are really interested in this model whereby clinicians are really using real time, and that term is a bit debatable, with timely data as much as possible at point of care to really drive this continuous practice improvement. And I guess we have a lot of data to our hand in the health system, in our EMR, electronic health records, but also other data sets, routine clinical quality registry data. In New South Wales Health, we have systems like QUIDS and QARS for healthcare acquired complications, but often there's key challenges to the access and the use application of these data at point of care. One of the issues might be around cultural barriers, but also training and a lot of behavioural barriers in terms of the application and use of these data. And there's other registries that exist, like the Australian Hip Fracture Registry or the Australian Stroke Registry, for example, that collect a lot of these data across the country as well. But how are these reports provided back to clinicians? How are clinicians making use of the data at point of care? So there's a lot of work going on in implementation science and translational health methods, really, around the behavioural science aspects of how do we feed these data back to clinicians and really act upon them to drive practice improvement. There's a lot of focus at the moment on the use of dashboards and electronic dashboards that are really guided by behavioural science approaches in terms of, there's so much data that we can collect, but what is it that clinicians want that's really important for them to guide their clinical decision making as well? Because I guess the more sophisticated we get with our health system IT infrastructure and wearables and a whole bunch of other electronic bits and pieces, we'll have all of this sort of routinely collected. So how do we filter and make sense of that and really get the best pieces when we need them to be improving our practices and our care as much as possible?
Thanks, Caleb. Well, we're coming towards the end of the session, and it's been great to hear from these luminaries and to hear about the great work and how the registry in Western Sydney is going to give us a much better picture of real-world data in frailty. We've heard about the assessment of frailty, and also we've heard about the potential for innovative models of care. And also from the chat, we've had some multidisciplinary feedback with people with a lot of technical expertise in how we can make these data more accessible and user-friendly. But just before we close, I think we've recognised, and as Richard has mentioned, this is a very fertile area for research, and also kind of perhaps the new paradigm of healthcare, which is multimorbidity, complexity, and frailty is part of that picture. So I just wanted to end by asking our luminary panellists which one closing thought they would like to leave with colleagues that have joined us today that they think will move the the field of frailty in health systems forward and how that would potentially improve patient outcomes. Richard, do you mind if I start with you?
Not at all. I just want to drop a little bit of a bomb right at the end by saying that there's been some recent evidence that frailty is actually a major driver of dementia. Very, very interesting. But my closing comment is that this is everybody's business. We're all impacted by frailty, maybe personally as well. So it's everybody's business. We all need to get on the game here.
Thank you, Richard. Steve?
Yeah, I think Richard hits the nail on the head, you know, that it's everyone's business in the hospital. And I'd like to think that often in the health system, we're good at thinking about that. We're often judged by the way that we treat our most vulnerable patients and families. And frailty is one of those areas where we've recognised a vulnerable group.
Thanks, Steve. Julie?
Yeah, thanks, Trish. In my closing remark would be that frailty is not in the eye of the beholder. So please use a validated frailty in the clinical setting.
Right. Caleb?
I think I'm just reflecting on the value of consumer engagement in research as well. And this is probably off the back of our group the other week, but really listening to what's important to patients and what matters to them. And really engaging them in research and just how critical and fundamental that is to everything that we do as well.
Well, thanks so much. You know, I think that notion of vulnerability is really a call to action for all of us. These people are often overlooked and invisible, and because of some of the cognitive issues, find it challenging to advocate for themselves. So I think as healthcare professionals, we have a real imperative to move this field forward. So it leaves me to really thank Caleb, Richard, Julie, and Stephen for joining us today to give us an insight into their important work. I would also like to thank Jill McGahn and David Currow, who've organised this fabulous Luminary session, which allows us to come together, reflect on research that's been done, but perhaps more importantly today, I think we've got a roadmap for important research that needs to happen in the future. I'm so impressed with the audience to voluntarily on a long weekend afternoon to come between 4 and 5 p.m. and to have over 55 people here. You know, hats off to you, but I think it's a testament of the importance of this topic and the commitment of many people to making a difference. We really hope you enjoyed the discussion as much as us. The event was recorded, so everyone will receive a link via email to the recording. And I hope you have the opportunity to play it again and reflect, or perhaps share it with your colleagues in the clinical area or your students. So again, my sincere thanks to everybody for joining us this evening. It's a long weekend. Poor Richard is on call, so we hope for quietness over your your Thursday evening.
Thanks, Trish.
But for the rest of us, we're starting a long weekend. So again, my sincere thanks to Jill and the team, and hope you will join us for these future Luminary sessions, which are really allowing us to have some crucial conversations on the critical issues that we face today. Thank you.